All right, I think I'm getting the go-ahead to start. So I actually don't see anybody, so I'm assuming there's people online. My name is Jordan. I'm a part of CAIS, and today I have the pleasure of introducing one of my good friends and colleagues, Dr. Patel, to talk to us about his work. I've known him for a few years now. He was actually a CAIS fellow with us a few years ago, where we worked on some pretty cool projects together, and got to learn a lot from him. But since he's moved on from his PhD at the University of Chicago, where he finished up a degree in social work and biostatistics, so he's a really has a really nice background in being able to look at different social problems. In particular, I think we'll be talking today a lot about healthcare, and has a really strong background in stats and machine learning, etc. Right now, Dr. Patel is at Harvard Medical School in the Institute for Healthcare Policy. I've read a lot of his most recent work, which we'll be going over today, focused on technological innovations, healthcare service delivery, access to mental health, et cetera, et cetera. So I'll keep it brief and short and let Dr. Patel sort of take it over from here.
Hi, it's a pleasure to meet everybody, and I look forward to presenting to the group today. As Jordan mentioned, I'm a postdoc right now at Harvard Medical School in the Department of Healthcare Policy. I'm a former CAIS fellow too. Certainly enjoyed my time working with Jordan in particular as my primary mentor, but then the rest of the team, Eric, and Bistra and the rest of the CAIS faculty. And so I'm going to present my screen. And what I want this to be is somewhat interactive. I'm going to try to keep my eye on the chat. I'd love for you all to ask questions as I go through the presentation. This is, a very much a claims-based analysis. And so I feel like there's a lot of opportunity for individuals that are both on the CS and on the social work side to lend your expertise to these types of questions when we think about equity and access to care, and in particular, access to telemedicine care. So I'm going to go ahead and share my screen now, and I'll begin the presentation and emphasize again that I would love for this to be as interactive as possible. And so please feel free to share or interrupt at any point. Can people, I think you should see the slide. Okay, it should say telemedicine use during the COVID-19 pandemic. Yep. And so today I'm going to discuss telemedicine use during COVID-19. And so one thing I want to emphasize is prior to the pandemic, telemedicine was really a niche field in the area of technology and healthcare. Very few people used it, even though it was one of those very interesting technological innovations in healthcare delivery. And one thing that became a big challenge within, it shed a light on telemedicine in particular, was during the pandemic, where telemedicine use increased dramatically. Nearly 1/3 of all healthcare in the outpatient clinic setting, when you go visit your doctor for your annual checkup, was happening via telemedicine, which is huge. Less than 0.5% of visits were occurring via telemedicine prior to the pandemic, just to show the enormous growth of telemedicine. Our group has done a lot of interesting work looking at the impact of COVID-19 and focusing specifically on telemedicine. We've looked at telemedicine's general growth. We've looked at the treatment of opioid use disorder. We've looked at telemedicine use across different patient groups, answering questions of equity. We looked at community factors driving telemedicine use, which I'll be presenting today using some machine learning estimation. We've looked at pediatric and diabetes care as well. We have some topics that we're also exploring now, looking at alcohol abuse treatment, initiation of opioid use disorder treatment, and anxiety, depression care as well. And so one thing I want to point out. So this was a graphic that was of our work that was published in the Wall Street Journal, but it looked at telemedicine use before the pandemic and telemedicine use during the first couple months of the pandemic. And what I want to really emphasize here is that yellow dot, which represents the proportion of visits in the outpatient clinic delivered via telemedicine. It's quite small. It was less than 1% prior to the pandemic. And while the bigger circles shrunk, which means less people were going to doctors' offices, you see that the percentage of visits delivered via telemedicine grew from 0.8% to 30%. And so the question I want to ask, that I want to explain, is what policies led to the dramatic growth of telemedicine during the pandemic? And how can we really understand this new tech innovation that exploded in a couple short months during the pandemic, and understand what led to its dramatic growth? So prior to the telemedicine, only people living in rural areas that were determined by the USDA county assignments could use telemedicine. Reimbursement was not at parity to in-person visits, meaning if a doctor gave a visit via telemedicine, he or she was actually paid less than an in-person visit. So there's incentives on the provider side to use in-person care versus telemedicine care. You could not conduct a telemedicine visit from home. So what if you were that rural patient and the closest hospital near you was an hour away? Well, to use a telemedicine visit, you would have to drive to that hospital. They would then put you in a room with a headset like this and internet access, and you would call in that specialist who might have been on the other side of the state. The patient-provider relationship had to be established in person. So if suddenly I lived an hour away from the closest primary care physician and I just wanted an annual checkup, I had to actually see that physician in person first before we could then continue our relationship through telemedicine. And there were state licensure requirements, meaning if I was a patient living in Illinois, but on the Illinois-Missouri border, I couldn't get care from a doctor that was 45 minutes away in Missouri due to state licensing requirements. Before COVID-19, telemedicine was very rare. Right here, it's showing less than 0.5 visits per 1,000 individuals per every 3 months. Very small use of telemedicine. It was quickly accelerating in rural areas, but it was less than 1% of individuals on commercial insurance were using telemedicine before the pandemic. So what happened during the pandemic that caused the enormous growth of telemedicine? Medicare expanded the procedures reimbursable for telemedicine, meaning that there were certain procedures, doctor's visits, that Medicare would not reimburse if it was done via telemedicine. They would only reimburse it if it was in person. One procedure would have been an eye checkup with an ophthalmologist. It expanded it to all individuals living in rural and urban areas. Reimbursement was now at parity, meaning a doctor was paid the same for a telemedicine visit as an in-person. The visits could be done at home, meaning if I was at home and I had a smartphone, I could FaceTime my doctor. And if I lived in a rural area, or if I was an individual without internet access at home or a smartphone, I could actually call my doctor and have that visit through a landline phone. You could establish the relationship via telemedicine. You no longer had to do it in person. And if I lived in Illinois, I could now see a doctor living in California. And so the state licensure requirements were waived. So a lot of our work was focused looking at the commercially insured. One thing that I want to emphasize is claims data. It provides an enormous opportunity to examine healthcare utilization and spending at a population level. And it provides the sample size needed in order to run some of the sophisticated analyses, quote unquote, big data analyses that individuals, I believe on the CS side of the fence, would love to have. And certainly those are skills that I enjoy, that I lack, but I would love to collaborate with individuals that have those skills. And so for a lot of the work that we've done, we focused on data from Optum Labs data warehouse. Optum Labs Data Warehouse houses all of, is basically the research arm of United Health, and it accounts for about 13% of the commercially insured population. And so the beautiful thing about Optum Labs is there's about a 2-month lag on the data. And so the data is very much up to date. And so what we did is we did an analysis on 16.7 million commercially insured and Medicare Advantage enrollees with 12 months of continuous enrollment. And the reason why we imposed the continuous enrollment is with commercial insurance, there's a lot of churning. People get a job, people lose their job, and so they're moving in and out of the insurance. Whereas with Medicare and Medicaid, you typically have a pretty stable cohort of individuals that have insurance for a period of time. And our study period was January 1st, 2020 through June 16, 2020. So this analysis really focused on the initial weeks of the pandemic, around March 13th through June 16th. And the outcome that we looked at was the total percent of outpatient visits delivered via telemedicine. And I'll talk more about that soon. So as you can see, the blue line indicates the pandemic, which was March 13th, when the president at the time issued the order, the emergency declaration, and Medicare then expanded telemedicine reimbursement. And you can see prior to the pandemic, we're at 0 visits per 1,000 members, and then it explodes to almost 30 visits per 1,000 enrollees. And you can see that there's a substantial drop in in-person care. It almost drops to the same level as telemedicine, and this is in the outpatient clinic. And the growth in telemedicine in some ways made up for about 1/3 of the drop in in-person care, which was remarkable. One thing to keep in mind, this is 30 visits per 1,000 individuals per week. Before, on the slide earlier, with the same population of commercially insured, it was less than 0.5 visits per 1,000 per quarter, per 3 months. So just in such a short period of time, there was a remarkable growth, right, in telemedicine. And we've looked at this data across different commercially insured. And so this is data from another analysis that I wasn't a part of, but it looked at the drop in outpatient care. This is baseline, which was the prior year, 2019, and this is 2020. And here are the initial weeks of the pandemic, and you see the tremendous drop in overall utilization prior to the pandemic. And so one of the questions that we answered was, which doctors are using telemedicine? And so this graph provides a proportion of the percentage of endocrinologists, neurologists that used telemedicine before the pandemic, 0 almost, right? With the exception of psychiatry, social work, and psychology. So the mental health field had been using telemedicine for therapy or psychotherapy purposes, but still that was under 10%. And look at its growth during the pandemic period. This is the proportion of doctors with at least 1 telemedicine visit. You see it growing remarkably. And you see endocrinologists using almost 70% of endocrinologists delivered care via telemedicine. And you see that there's variation, but there's substantial growth across all clinical practices. And you see that the ones that are still under 10%, ophthalmologists, physical therapists, optometrists, chiropractors, so the practices that require some form of a physical examination obviously would have a difficult time using telemedicine. Remarkable growth. And then you look at for what conditions was telemedicine growing. And so here along the x-axis, this is the percent of total visits delivered via telemedicine. And this is the drop in total visits in person and telemedicine from baseline. And as you can see, there's a linear relationship. For the conditions that were able to be treated via telemedicine, which was predominantly dominated by behavioral health conditions, anxiety, bipolar disorder, depression, anxiety, stress disorder, and so forth, you see that they were able to be treated via telemedicine, and these conditions experienced the lowest drop in total outpatient care volume. Whereas on the other side, cataracts, conditions that really required a physical examination that were not able to transition or pivot into telemedicine, these conditions experienced the greatest drop. And so I segue that these are interesting ways to look at how telemedicine, there was variation in telemedicine use by clinical specialty and by condition. But the questions that we were really interested during this period was really questions of equity in telemedicine use. I think there's a growing concern that as the medical field introduces more technological innovations in delivering care, one of these is telemedicine. The mHealth app is another one. There's growing concern that the growth of telehealth or just tech in general within healthcare delivery, does it further exacerbate disparities in care? It is well documented that patients that live in urban areas receive more care than patients in rural areas, that white patients access care at greater proportions than Black and Latino patients. Individuals with high economic standings access care more than individuals with low socioeconomic standings. And the question becomes, does technology lend itself to further exacerbate it? Meaning, when technology is introduced to healthcare, are wealthier patients going to access it, urban patients, and white patients going to access it at greater proportions than more disadvantaged groups? And so one question that we ask, and this is more of a philosophical question from from a healthcare equity standpoint, from someone that comes from a social work background, the question first becomes, has telemedicine improved or harmed access to care for disadvantaged populations? And has it further exacerbated existing disparities in care? And so here I present two graphs, and I present rural and urban patients. And so if we just focus on 2017, we see that rural patients with a diagnosis of mental illness in 2017 received less specialty mental health care visits per person than individuals that lived in urban areas. About 1.3 visits per rural individual versus 2.6 visits. And this is even more pronounced when we look at individuals with more serious and disabling mental illness, specifically bipolar disorder and schizophrenia. And so the philosophical question that we ask really is, what do we consider equity to be? If equity means that patients in rural America receive the same number of visits as patients in urban America, then we would want the growth in telemedicine to be greater in rural areas than urban areas. If we think that these questions of equity are different, then the growth of telemedicine would vary with regard to what we think appropriate levels of care would be for disadvantaged groups. I mentioned this slide because there's this constant conversation about the digital divide. And so there's this idea that the digital divide might limit or inhibit individuals from low socioeconomic, ethnic minority groups, or in rural areas from accessing care because of their limited access to digital technology like smartphones and their limited access to broadband. And this just emphasizes that point. You see that white individuals, this is percent of Medicare beneficiaries without digital access. So fewer white individuals are without digital access, whereas greater numbers of Hispanic and African-American Medicare patients are without digital access. Similarly, this is basically based on, this is on income level. So people that are more poor or have people that have more income have greater access to digital technology. And so for our analyses, the way we measure health equity is really in three ways. We want to understand urban and rural divide. We want to understand equity based on race and ethnicity, and also by socioeconomic status. And so when we look at who's getting telemedicine care, and so right here, this slide measures the percent of individuals, the percent of visits delivered via telemedicine. And so here, for example, this would say 40% of visits were delivered by telemedicine. And the orange represents during the pandemic, and the blue represents prior to the pandemic. And we see that younger enrollees are, telemedicine use is more common among younger enrollees versus older. which aligns with our hypothesis because younger individuals might be more adept to using technology and having broadband access at home. What we found here is urban enrollees have far more access to telemedicine, almost 30% of visits, than rural enrollees, where we find that about 23% of total visits were delivered via telemedicine. When we look at income and percent white, we're finding mixed findings in the literature. Our analysis showed that individuals with low median household income or low income actually use telemedicine at greater rates than individuals with high income. And we found that individuals living in counties with fewer white individuals, this is based on census county level analysis, actually had higher rates of telemedicine use than individuals in counties with higher proportion of white individuals. And we were really surprised by these findings. And so when we compare it to other data that looked at when we compare it to non-commercial groups, specifically Medicare patients, we find the same thing, that the percentage of the fraction of Medicare patients who use telemedicine across white, Black, and Hispanic groups are about the same, hovering right around 35%. But when we look at the urban-rural divide, we find that there's a big contrast. Almost 42% of individuals living in large metropolitan cities use telemedicine versus a little about 20% in rural areas. And so this really lends itself to us trying to understand at a community level, what are the community level factors that drive telemedicine use? So these analyses that I showed thus far, these are patient level or person level analysis. And these are adjusted differences. But the question lends itself that are individuals who live in communities with certain characteristics more or less likely to use telemedicine? And a big key question is, how can we write policy at the county or state level or the federal level as we move beyond the pandemic? And as you can see here, that there's wide variation in telemedicine use. And so this is the fraction of total outpatient visits delivered via telemedicine. The dark blue indicates high volume or high percentage of telemedicine use, whereas the lighter shade indicates lower. And as you can see, the map is colored differentially across the board. That even though telemedicine use increased during the pandemic dramatically, there was wide variation in that use. And so this lent itself to the question, there's substantial geographic variation in telemedicine uptake during the pandemic. What drives this variation is unclear. And so can we examine county level factors that are driving telemedicine use among commercially and Medicare Advantage enrollees? And so for this analysis, we used the percent of total outpatient visits delivered via telemedicine as our outcome. And so for example, counties with 40% versus counties with 1% of total outpatient care delivered via telemedicine. And we wanted to adjust for every type of county level characteristic that we think would be associated with telemedicine use. And so we looked at population density, which was our proxy for rurality. We looked at race at the county level, income. We looked at broadband availability, and we looked at healthcare resources. So we looked at the number of hospital beds per capita in that county, community health centers, physicians, and advanced practice registered nurses. And so what we wanted to understand is, even when we adjust for all these factors, what are the salient factors driving telemedicine use at the county level? We also looked at pre-pandemic telemedicine use. And we use this as a proxy for telemedicine infrastructure. And so the idea is counties that were using telemedicine at higher rates prior to the pandemic were likely more easily able to pivot into providing majority of their care via telemedicine than counties that had low telemedicine use prior to the pandemic. And we also adjusted for COVID-19 cases per capita. Our hypothesis was counties with higher COVID burden early in the pandemic were more likely to use telemedicine because individuals might have feared for health and safety reasons. Jordan, that's a great question. We're recording, but I'll say this. If you look at a lot of the articles in JAMA, and you Google 2021 and 2020 and put the word concentrated disadvantage. So the question Jordan asked is, were you able to include disadvantaged data at the county level, such as concentrated disadvantage? I think a lot of these social work concepts and theories are beginning to, concepts, theories, and sociology as well, are beginning to find its way into the healthcare literature. And so a lot of research as of late, especially in 2020, 2021, when COVID shed a light on a lot of the disparities in the healthcare system in particular, started using these concepts such as concentrated disadvantage as a predictor for healthcare utilization, spending, racial inequities in access to care. And so the short answer is no, but the bigger and more complicated response to your question is there's a lot of opportunity to start integrating a lot of these concepts that have been in social work and sociology for 2 decades into the medical and healthcare literature. So we divided our measures into tertiles for meaningful interpretation. I recommend you looking at the appendix for some of the folks that were interested in understanding how we assess positivity violations, looking at the propensity score, and ensuring that there was enough overlap across treatment groups. And that's what determined whether we use tertiles, quartiles, and binary outcomes. Now, in terms of our method, I will explain the method we use, but certainly would love to have folks on the call that are far more knowledgeable of targeted maximum likelihood estimation and just machine learning in general. And so for this particular analysis, we brought in our ML expert, Sherry Rose, and specifically implemented TMLE, targeted maximum likelihood estimation. And so for, I'm going to skip the second bullet, as I feel like folks on the call likely understand this far greater and far more specificity than myself. But this was used, I applied this using R, using the superlearner and TMLE packages. And as part of this TMLE procedure, I used an ensemble to estimate the outcome regression and propensity score regression. And I included random forests, artificial neural networks, generalized additive models, generalized linear models, NNLS, and extreme gradient boosting. And I set our random forest to various minimum node sizes, 50 to 200 in increments of 50. And for my artificial neural networks, I set the weight decay parameter 0.01. And here's the outcome. I'm not going to go over all the estimates, but I want to say that we ran a sensitivity analysis using just a general linear regression, and we posted that in the appendix of this paper. A lot of the general magnitude and the direction of our estimates were highly comparable with the exception of a few. And I want to point you to that paper to look at the comparisons between the OLS output versus the TMLE output. But what we did find with the TMLE output is urban areas had 30% more telemedicine use versus rural areas. This was a 7.5 percentage point difference, meaning in urban areas, there was a 7.5% percentage point greater percentage of visits delivered via telemedicine than in rural areas. That's huge, huge. And this was even after controlling for every healthcare resource factor we thought would be associated with telemedicine use. For broadband coverage, obviously you need broadband to use digital technology and FaceTime your doctor. Local COVID-19 burden, race, ethnicity, SES, and telemedicine use prior to the pandemic. So we threw the sink in this model, and we still find that rural areas are accessing telemedicine at 7.5 percentage points less than urban areas. And one thing I want to do is position our findings within the broader literature. One thing we're finding is there's mixed findings when we look at telehealth use by race, ethnicity. Some studies are finding less telemedicine use by race, ethnicity. Others are finding more. but we're consistently finding across all literature that rural areas have consistently less telehealth use. Some policy implications that we can have is targeted policy addressing access for rural patients. So we need to think about broadband and digital technology access, particularly in rural areas. President Biden's new budget plan included almost 75 million or 100 million for broadband in rural areas. We might want to re-envision the payment rate for telemedicine in rural areas, meaning that doctors are paid more to provide care to rural patients via telemedicine to further incentivize. This was something that they did with the ACA expansion, where doctors were paid higher rates for treating primary care Medicaid beneficiaries to encourage doctors to see patients that were from lower socioeconomic backgrounds. I want to highlight some of our other work really quickly. We've looked at telemedicine use for diabetes care. We found that for diabetes care among individuals with type 2 diabetes, 25% of diabetes care was happening via telemedicine in the early period of the pandemic, 13% in the later months of the pandemic. This was data for the entire year of 2020. We also have done some work with telemedicine for postpartum depression. And we find that consistently through 2020, almost 60% of psychotherapy visits for women with postpartum depression are delivered via telemedicine. I want to just touch a little bit on some of the next steps or questions, and particularly focusing on individuals with more sophisticated CS backgrounds, machine learning backgrounds, thinking about questions of digital redlining. And so I talked about the digital divide, which is that patients from lower socioeconomic backgrounds in rural areas don't have the prerequisite technology or broadband coverage to use telemedicine. But there's this concept of digital redlining, analogous in some ways to just redlining in terms of segregation in the US, particularly in large metropolitan areas. And it's this concept that not only are people segregated by where they live, but by the information that they receive. And so there's this whole concept of digital redlining or telemedicine barriers across what they call digital redlining areas. And this is something that I'm trying to figure out how we can measure quantitatively. There was this piece in JAMA and Circulation where cardiologists that put remote detection tools for patients to monitor their hearts were saying that patients living in racially segregated areas, historically racially segregated areas, they were having a more difficult time monitoring their heart pacemakers than patients that were living in more affluent areas. And so they wrote this piece about digital redlining and its impact on patient monitoring or as in the field of cardiology. There's another concept of data bias, that a lot of healthcare policy, healthcare adjustments are made on prior year data. And so you think about Medicare adjustment, risk adjustment, it's based on the prior year data. So there's this knowledge that if the data itself is biased, that when you run the algorithm, it's just going to perpetuate the bias. And so an area that I'm working on or been thinking about greatly is this idea of bias in data, and how can we transform data to make the data that we feed into an algorithm more equitable and more inclusive. And so if I'm using these terms very broadly and inappropriately, but if rich patients are accessing care for illnesses that rich individuals typically get at higher rates, and that's reflected in the data, whereas illnesses that afflict poor patients and they're accessing care for those illnesses at less rates, what happens when we have a data that's skewed towards treatment for, quote unquote, illnesses that afflict rich patients at higher rates? When we use that data and feed it into an algorithm, how is that algorithm going to perpetuate that bias? And so that's something that I've been thinking about, but I'm limited in terms of my level of sophistication in how to then apply some of those algorithms and how to transform these data into making the data more equitable and ultimately feeding it into an algorithm that then would be more equitable in terms of adjustment. And I want to just end by saying thank you. I'm hopeful that I intentionally kept the presentation about 35 to 40 minutes. So I'm hopeful that this would then trigger some conversation with the rest of the group. And I'm really curious to hear your thoughts, feedback, applications as to where you think next steps can go, curiosities that, that you have. And so I'm going to stop sharing my screen now.
Great, thanks a lot. Yeah, so if we could, filter any questions into the Q&A. You'll have to type it into the Q&A. I don't think you can type it into the general chat, but this is a great opportunity for everyone to get some more information on this data, on these procedures, etc. I know I have a couple questions, but I'll kind of hold off until maybe a few minutes to see if we have any questions from folks. Doesn't look like it, so I'll just ask my questions. So this is great. So the reason I asked about economic disadvantage, concentrated disadvantage, not only because of some of this work that you and I did years ago, but Beaster and I have recently kind of dove into looking at similar things, but within the substance use treatment context. And maybe for the first time, I don't know, we were able to use some interesting ML models to determine how important sort of environmental level variables, such at the census level, neighborhood level, how important these things are when predicting relapse to opioid use, so following treatment.
Yep.
So I wonder, and so I guess I should say the results really glean some interesting light in that in all of our models, within the top 1 or 2 important rankings was an environmental level variable, whether it was poverty, rural versus urban, which was a big one. Actually, it popped out in every single model, showing that people lived in rural areas were more likely, had a quicker time to relapse, more impoverished areas, higher concentrated disadvantage, etc. I'm wondering, what do you think if you included this, or will you include this? How is this going to pan out in terms of healthcare access? Are we going to see similar things, or are there going to be interactions? What do you think?
You know, that's a really good question. And it's something I've been thinking about, because we included race, ethnicity, we included an income, rurality. And I'm sure, Jordan, as you know, these factors are likely very highly correlated, right?
Yeah.
And that's something that I've been thinking a little more deeply about, that in some ways, healthcare resources is a function of where you live. And so when I incorporated a model where I incorporate healthcare resources, but also incorporate factors that are highly predictive or correlated with healthcare resources, like rurality, population density, or like the number of, race, ethnicity, and socioeconomic status, I almost feel like these are trees. Like healthcare resource, or where you live, then influences your healthcare resources, which then influences your ability to access healthcare resources through a technology like telemedicine. And so part of me has been thinking a little more deeply about, is really the appropriate application of putting this all in a model and seeing which is the most salient feature, or are there ways to model this in such a way that you can tune the parameters, where if you're able to change the demographics of a population, how then does that feed into the local healthcare resources? Or how does it then feed into people's digital access? Or if you change the broadband access within a community, but then you also increase the number of physicians in that community, how does increasing both those factors influence the number of telemedicine use or telemedicine access? I feel like there's got to be more creative ways to think about this, because these different factors don't exist in silos and don't independently impact an outcome, but in some ways are all highly correlated with one another and then impact the outcome. So I say all that to say there has to be more creative ways to think about how these different levels affect each other, and then how that ultimately impacts the patient.
Yeah.
I haven't quite yet thought through what the appropriate way of doing that is. There's this individual at Harvard who went to my high school, ironically. He's a professor, but he has these models where he looks at these tiers, where he says, this tier then affects the next tier, which then affects the next tier, and then affects the person. And he creates this hierarchy, and he then is able to tweak these parameters at each of the levels and shows the trickle down effect it has at the patient in terms of the outcome, the number of visits he might then get. I would be so curious if there's a way to examine these questions through that framework. I don't think that traditional statistical models lend itself to doing that.
Right. Yeah, I tend to agree. I think we have a couple questions. I have one that just popped in here to the chat. I don't know if you can see it. Can you discuss policies that can ameliorate digital redlining that marginalized groups experience?
That's such a good question. So this is something I've been reading a lot about lately, and it's super fascinating. And so there's the more traditional, like digital redlining questions that you can explore looking at FCC data. And so FCC at the census level publishes how much, what proportion of each census tract has and of what internet speed. And so there's this one concept that broadband and fiber optics were basically created across what they call this digital red line or racial segregation lines. And so there's some work that overlaps like traditional racial segregation in the city of Chicago, and it overlaps it with the FCC data, and it finds that there's a high correlation, meaning that companies built broadband infrastructure and fiber optics based on some of these lines. There's this second wave of research that looks at the information people are seeing on social media based on these lines. And for example, myself, I see an ad everywhere of telemedicine. See a therapist through telemedicine. Click this button, get your first free consult tomorrow. And there's this literature that says if I lived on the south side of Chicago, I may not see that ad. And so the information I'm exposed to varies based on that. And so to answer your question, I think that the first part of the question is highly underexplored. And so something that I'm really interested in thinking about is how does this concept of digital redlining map itself onto this idea of technology and healthcare access? And so I think understanding how that overlap and that relationship looks like, we can then think about the policies and that can lend itself to some to the specific question you have. I can share with Jordan and the rest of the folks some of the really interesting literature and philosophical papers that are out there in conceptual papers about digital redlining. There hasn't been a lot of work that translates that into, is this phenomenon, how pervasive is it across different fields?
Yeah, that's a great point. You do have a question here in the Q&A.
I see yours and the one on digital redlining. Is there another one?
Oh, if you just,
yep, I see it.
The Q&A, I think.
Yep. You see that requirements to make nowadays everyone's, that's a really good question. I think one thing that when you look at claims data, it's so powerful in terms of giving you information about healthcare utilization, because you have all the claims for everybody. One of the challenges is it doesn't necessarily lend itself to some of these more nuanced questions that you're raising regarding what fraction have smartphones, 4G, 5G connectivity, and so forth. I don't have a lot of knowledge about. So the question says, You said that rural people generally don't have the broadband requirements to make telemedicine visitations. Nowadays, everyone has a smartphone with 4 or 5G connectivity. Isn't that good enough? So I think the first question so the first point I'd make is you're absolutely right. Like I would agree with that sentiment as somebody living in Boston. If I didn't have internet, I could very easily, depending on where my apartment was situated and where my window was, I very easily call my healthcare provider on my iPhone. The question is, does that same infrastructure for 4G, 5G exist in rural areas? If it does, you're absolutely right. But I'm not sure if it does. That's my first response. My second response is it's one counterpoint is there's the part of the Biden plan is they're creating what they call these telehealth centers in rural areas where patients can go to these telehealth centers. So for example, the USDA just gave $100 million in funding to University of Georgia and about 6 other nonprofits to build about 25 telehealth centers across all the really rural areas in the state, where patients can go and basically receive mental health care, substance use treatment, and treatment for chronic illnesses like heart condition, diabetes. And their hope is it then stimulates it. So my answer is, I think there's a lot more work, Nishant, on this area, looking at connectivity in rural areas. There's a paper that I reviewed recently that should come out in JAMA that looked at digital access in rural areas, but it was a survey for patients that they asked them about their digital access. So they asked about broadband at home, but also smartphone and smartphone speeds. So I'm hopeful that when this comes out, maybe that'll elucidate some of the answers. I don't remember them off the top of my head. But I also think that there are other policy measures and a lot of money being invested in rural health, specifically for telemedicine access.
Great. Let's see. Any other questions? Got a few
I
more.
have a question.
Yeah.
Sorry. Hi, Sadiq. Thanks. Super exciting talk and really important work. And obviously understanding how telemedicine is being used and also how can it impact for good or for bad the health outcomes is very important. And so you already talked about the difference between rural versus urban.
Yep.
Have you looked at within the rural areas, are there some areas that are more successful at using telemedicine than others, and maybe try to basically replicate your analysis, but just within the rural areas where you can try to tease away which are possibly some of the characteristics of rural areas that help them succeed better than other rural areas? Because obviously there's so many differences between urban and rural areas that cannot be overcome, cannot be solved by huge investments. That would take years and years, right? But within rural and rural, maybe there's things we can learn.
You're absolutely right. And I think you read my mind for my some of the work I'm hoping to spearhead in the next year. I think you nailed it on the head with there's so much attention right now on rural health. In particular, we were presenting some of this work to the panel of health advisors for the CBO, and one of the recommendations was we really need to look at equity within rural areas and try to understand if there's variation within rural areas and learn from the communities that were able to implement broadband. I think one thing that we find within the rural definition by USDA is if you look at their definition, it's a 4-tiered system. You're either urban, so that basically lumps in suburban and what we would think urban areas to be like Chicago, LA, but also the neighboring suburbs. And then with rural areas, they have 3 tiers. It goes from kind of rural to medium rural to very rural. And I think that we can start learning from differentiate, how do these 3 areas vary across the spectrum of what the USDA defines as rural, but then also to think about what we can learn from areas that are able to successfully implement telemedicine or any type of technology as it relates to healthcare, and what we can do and what our lessons learned that we can then trickle down to areas that have not been as successful? I think that's a very important question and an important next question. And I think another next question that we hope to have, once we have maybe a year and a half of data beyond the pandemic is patient outcomes, right? Yeah, rural areas are using telemedicine at lower rates than urban areas during the pandemic. And at baseline, they were already using healthcare at lower rates. How has this not only affected care access, but patient outcomes? And are rural areas also falling further and further behind when it comes to patient outcomes? And so that's something else that is on the radar, and we're just waiting for the data to catch up so we have enough of a sample and enough data time that we can make some strong recommendations.
And so back to like geographic variation and trying to really bring this back to policy recommendations, is there also geographic variation in terms of the way that telemedicine is provided, like between states, or maybe between providers, and then providers being more predominant in one area than another, where again, you can maybe get some insights into what works and what doesn't work for rural areas, for example, or generally?
Yeah, that's some work that I'm not being directly part of, but I think you nailed it when you said providers, or I might put that under practices, right? And so one thing that we're finding is some of the big providers versus the small practices with fewer physicians, maybe 3-4 physicians, 1 or 2. Some of them were able to effectively just transition quickly into telemedicine care, got rid of their office, and basically changed their entire practice model. Some shut down because it was just, the patient volume was so low that it was just, it cost them less money to just shut down than it was to stay open, pay staff, pay for office space, but just receive far fewer volumes. Another area where just these new telemedicine only companies that were popping up that started to really dominate the space, where we don't have a physical practice, we just have doctors and they work from home, and we have this model where we connect you directly to them. And so I think there's a lot of opportunity at looking at between practices and more specifically what types of practices thrived and flourished during this period and what didn't. And I think there were a lot of economic implications for physicians in small practices during the pandemic. And so there's some work that other folks in the group are spearheading, and hopefully we'll love to share it with you. But I think there's a lot of opportunity to look at between practices, and then also look at between practices and look at the interaction between practice and geography as well.
Okay. Looks like we're down just a few more minutes. Maybe one last quick question, or
maybe I have a question for the audience, if that would be okay.
That sounds great.
So there's a lot of, there's a lot of opportunity. So one thing that I've increasingly learned is my time at CAIS, I left with the idea that everyone is doing ML in some form of social research or health research. I use that term broadly. And now I'm learning more and more that a lot of the work that we do, and understandably so, is dominated by more traditional health econometric models. And so a lot of it is diff and diff, propensity score matching, regression discontinuity designs. And you see like that small circle of machine learning is growing, but still is a minority of the methods used. Some questions that I have is, and just a broader question, and I kind of leave it as food for thought, is there are some questions that I just can't wrap my head around how we do it using regression, or using some form of a causal inference method that draws from a regression design or model. And my question is, are there specific ML models or techniques that we can introduce that do some of the things that that maybe traditional standard statistical modeling can't do? And I think of that in the question of data transformation, being able to feed data into an algorithm, and how to continue to transform that data over multiple iterations to make that algorithm the outcome of that algorithm more equitable because we've made the data more equitable? Questions like that. And so I would be really curious, for folks that would be interested in thinking or brainstorming these types of questions, food for thought. Would love to have those conversations.
I think that's a great point. I know we're running low on time. So if anybody, I'm sure you're okay with this. Do you have your contact info?
I do. I'm going to
Just type it into the general chat, maybe. I don't know if everybody can see that or not. I have no idea.
I'm doing it right now.
But I want to thank you for joining us. Always good seeing you. It's been a while.
Yeah.
You're doing some great work, publishing in really top tier journals already. So this is super exciting. One of our own CAIS fellows here, Dr. Patel, thanks so much for joining us. And keep up the good work, man. Good seeing you.
Likewise. Thank you so much. What a wonderful opportunity. It's so great to see everyone. Jordan, Bistra, Eric, and special thanks to Haley for coordinating this.
Thank you. Thank you, Sadiq.
And I'll be chatting with you both soon. Thank you so much.
All right. Bye-bye.
Thanks, everybody, for attending. Bye.